Black and white.
It's not the worst thing in the world. All right, so we will get rolling, everybody. Thanks for joining. Hope everybody's doing well. Not a huge tectonic shift in the world, but a couple points to kind of review and talk about. So, as everyone's probably heard, seen, now appreciating, hopefully experiencing in your own practices, it definitely appears that everyone is now in agreement that we are, if not cresting, then potentially sliding down the other side of this most recent surge. As you'll see, each one of these little peaks, well, I shouldn't say little, but they get broader and they get higher. So how long we'll kind of rest on this kind of precipice of where we're at, not completely clear. But if you kind of follow the best fit lines, it looks like we should be heading in a downward trajectory at this point. Unfortunately, as we talked about, the mortality statistics, which do seem to be leveling out a little bit, probably have not roared their last roar at this moment. But certainly the new cases do seem to be subsiding a little bit. We are, if we follow everything that we're hearing, we may be looking at another potential surge with the variants come, roughly 6 to 8 weeks from now. However, there's more and more discussion about 6 to 8 weeks from now, everybody that doesn't have or doesn't live in a city that ends in Rochester will actually be experiencing some sun and warmer temperatures, and therefore will likely be in less confined and indoor environments. And so that may have a positive effect, even if variants do kind of start hitting the market. And at the same time, hopefully, if vaccine administration accelerates, and I realize that's a big if, then potentially we can balance against the variants to some degree. So, what's to come 6 to 8 weeks from now? I think if there's anything that we've all learned during this pandemic, is trying to predict what's going to happen 6 days from now is hard enough. 6 to 8 weeks from now is darn near impossible. And 6 months from now, we all may be outside in one big group hug, or the world could be on fire for all we know. So we'll get there when we get there. We'll find out. It'll be exciting. But as far as local numbers in the Finger Lakes region, we're definitely seeing some calming. As you can see, we did have 9 incremental mortalities in the last 24 hours. Again, it does seem that those are getting reported in fits and spurts. I don't know if that's real or if that's just how the numbers are playing out. You can see from a hospitalization standpoint, we were kind of on this downward trend, and now we've plateaued in the last 48 hours. Not necessarily terribly surprising, I guess, that there wouldn't be huge change in 2 days' time. ICU went up a little bit, but overall, I think the current rate of bed availability in the hospitals is about 33% of surge beds that are available, and about 24% to 28%, depending on the day, of ICU capacity that is available across the Finger Lakes. And so that puts us certainly out of the red zone. It puts us coming potentially out of the orange zone. And as many of you have probably heard, there is active discussion, if not outright plan, from the governor's office to start easing a lot of the orange zone restrictions. And I know that already feels uncomfortable to all of us, especially as we're kind of still sitting on the plateau of this most recent surge. Just think that now's the time that we'll start easing some of those restrictions. But to date, I have to give them credit. They seem to have followed those trends fairly well and predicted better than I probably could have. So I'm not going to call into question their choices at this moment. So that's about where we stand. If we look graphically, I don't know if it adds a lot to the discussion. You can see our rate of rise in positive cases has flattened a bit, not quite so exponential. The mortality has still not seen the same effect, but we would expect that to take at least another week or so before we start to see that plateau if everything does go the direction we think. Our positive case numbers largely flattening, certainly locally, but even statewide and to some degree nationwide at the moment. You can certainly see from the graph at the bottom right, the hospitalizations. We've definitely seemed to have crested that hill, and I think all the hospitals are breathing a little bit of a sigh of relief. It's just that ICU curve that we're waiting to come down the other side. Once the orange curve starts to take a turn, that's when we'd expect the gray curve with mortalities to start to plateau. And obviously we don't see that with the ICU curve yet. Hopefully we'll see that within the next days to a week, and then would anticipate the mortality curve to start downsizing shortly thereafter. If we go to the final curve, which is the new diagnosis in 24 hours, if you kind of draw the best fit line, it gets very zigzaggy here. And a lot of that, again, is just, it's been a little crazy in the last week or two. But if you kind of pan out the best fit line, you would see that we are kind of coming down off the plateau a little bit. When the public health folks modeled out, they've about weekly now, they've been modeling what the worst case scenario, best case scenario, most likely scenario. The most likely scenario is now starting to get much, much closer to the best case scenario in many ways. And we are moving farther and farther afield from the worst case scenario. So remember, a few weeks back, we were talking worst case scenario was a 10x experience from what we'd experienced in the first surge back in May, June timeframe. We seem to have kind of hovered in the 5x kind of zone. And now we seem to be kind of coming off that model even a little bit more. So that's good news. And as you'll see here at the next slide, what we're seeing here locally is really reflective of what we're seeing in counties across the Finger Lakes region. Everybody seems to be kind of cresting and coming down the other side at this point, which is good. That's good all the way around. So we'll continue to follow. There's nothing else dramatic in the short term. The public health folks, and I'm guessing they're judging this by contact tracing, seem to be much more in the rah-rah that people are doing a better job of moving away from these congregate activities. Again, I hope that's true. Nothing like a good surge to remind people what they shouldn't be doing. And then obviously we'll see how the next week or two goes, and hopefully these curves continue to trend favorably. So that's kind of where we are for that. Now moving on to the testing discussion. The only thing that I wanted to point out is there has been some discrepancy locally in the pre-procedural allowances. What does that mean? So up until very recent, well, in the very beginning, pre-procedure or pre-anesthesia procedures required nasopharyngeal testing even for the asymptomatic individuals. As all of us could probably attest, nobody really loves nasopharyngeal testing, especially when they are perfectly healthy and are just going for a procedure. So as the rest of the world has gone to nasal and then now more recently allowing saliva-based PCRs, we have still been a bit more conservative. I would say New York State for sure, but locally still favoring nasopharyngeal swab. That has now relaxed. So while we will not be doing saliva-based PCR locally, if a patient from outside the local region has access to a saliva-based PCR test, they can have that done, and those results will be accepted for pre-procedural testing locally. Likewise, for non-anesthesia-based procedures, they will be defaulting to nasal-based swab rather than nasopharyngeal swab. So that will be a little bit more warm and fuzzy and well received by the healthy population that are going for the elective and scheduled surgical procedures, and hopefully, allow greater throughput with our being willing to accept a broader array of pre-procedural PCR-based testing. So just wanted to put that out there. If you have patients that live sane elsewhere who are coming in to get an elective procedure here and have access to a PCR swab, but it's a saliva-based test, traditionally they would have had to come here, get their nasopharyngeal PCR test before the procedure, and it may have even delayed their procedure if they hadn't done that. Now, even though we won't be doing the saliva test at this moment, we will accept, and I say we like I have some say in this, but the grander scheme will be accepting the saliva-based PCR if they are performed outside the immediate region, as long as those results are still copied and sent in to the center where the procedure is being done. So that's really the only update on testing. Otherwise, everything else we've talked about the high throughput machinery that's coming probably by the 1st of February seems to be a bit ahead of schedule. So we continue to look very good from a testing availability standpoint. There is, I don't know if this affects most of us directly, but for those who are going to the U of R pre-procedure testing site that is at Strong, it's moving down the hall. So if that means tremendous things to you, I'll make sure that we copy that for the update today in the email, just so folks know. I think most of our patients that were going for pre-procedural testing are now going to the East River Road site, which is exactly what we intended. I think it's only patients who are being seen either at the hospital or in one of the clinical spaces at the hospital, and maybe some of the employees who are going to the on-site pre-procedure testing spot. Again, they're just doing it for size and access, but no other major reason. So we'll put that information in there just so you have it. So that's all I have to say about testing. Now on to the vaccine. Lots of discussions. So first and foremost, I know that there are still some of you and or some of your staff who either because of post-quarantine restrictions for folks who had COVID and were not yet cleared to get vaccinated, or staff who were kind of taking the watch and see approach and make sure the rest of us didn't spontaneously combust when we got the vaccine, or people who just have had a change of heart finally and decide they want to get vaccinated now, that there are now more people who need to get vaccinated, and the links that we shared with you before no longer work. So we have talked to the U of R team. They're still conscientious about just sharing. Anybody can click on this button links because it just created pandemonium. So what we're going to do, and I know this is everybody's fun part, we're going to share another Excel template that will be first name, last name, and unique email that we need you to complete if you have any staff members, 1A healthcare providers that have patient interaction. Once again, I know this causes some tribulations for folks, but if you have a backroom secretary who may come forward and interact with patients, or someone who usually does interact with patients but does at times, that person can fall into the 1A category. If you have someone who cleans your office who will never, ever, 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 ever come into contact with a patient because they do it at 3 o'clock in the morning when patients are gone, they are not 1A. It's not so much any of us, but the person who is signing up to get vaccinated will have to attest that they meet those 1A criteria. So we're going to send out that template. I need you to fill that out. I will beg you to the end of my breath to not manipulate that template and do whatever fancy Excel tricks that you know how to do. Fill in the holes as they are presented to you and send it back. You do not know how hard it is to coalesce 50,000 templates where everybody put their favorite trick on it. So type the name in the hole, because if it's not, I'm just going to delete it just out of spite. We need you send that back. We will put it all together. Yeah, see, there you go. This is the not nice chat. So you send it back. We will put it all together, and then we are going to share that with the U of R team. They will then enter that into their database. What will then happen is the database will then send out emails to individuals as many spots as they have available for whatever amount of vaccine they receive that week. If they don't reply or there's not enough spots that week, they will get re-invited as soon as another vaccine clinic opens up. So it will be evergreen in that regard. Many of you reached out and said staff members didn't want to share their email, or they all wanted to use one office-based email. That's wonderful. They will just not get a vaccine. So either they have to have a unique email or this system will not work for them. Or if they all want to share one email, one of them will get vaccinated and the rest of them will have to watch. So everybody will need their own unique email and their own unique first name, last name for this to work. And that unfortunately is not my rules. That's just the way the system works. So I think I've beat that dead horse enough. So that we will send that out today. Please fill it out and send it back to us. And I anticipate the clinics for 1A vaccination for this week are full because there was just very little vaccine that floated into the region. But we do anticipate that there should be a slight increase if the gods are with us next week. And so, the number of people who are in the 1A category who haven't been vaccinated is dwindling, and hopefully the number of 1A vaccines will be going up. So there's that. So more to come on that. We'll send that out today. Next, as far as distribution of the vaccine, lots of people have asked, and I'll be honest, I haven't shared this not because I'm trying to withhold the information, but just because to some degree it's boring as mud, and also because it seems to change every 3 seconds. But people have asked, where's the vaccine going? How do we know that? So I'll share with you what I know for the week we are currently in. So in the Finger Lakes region, the FQHCs, and there are several of you on, so correct me if I'm wrong, none of them got more vaccine this week, is my understanding. All of the hospitals in the Finger Lakes region got a total of 2,000 doses of vaccine. Many got none. Wegmans alone got 1,600 doses. Several of the community pharmacies got doses. Almost all of the rest was held by the state and kept for the state-based pods. So there were 250,000 total doses for New York State. Of that, about 2.8% comes to the Finger Lakes region. I didn't do all the math, but that gives you a good breakdown of how much vaccine went to who. Next week, the anticipation is that the allocation will be 16% higher. So why that number? I don't really know, to be honest with you. But 16% is the number of the percent increase we expect to see. I do not know at this moment that means all boats will float 16% higher. That's what we will not learn until probably Sunday. So there will be 16% more vaccine coming into New York State. How the state decides to allocate that remains a bit unclear still at this moment. So we'll share that information with you as we know. Many of you have asked about your practices getting vaccine. This is what I'm getting ready to say is not information that's coming from the Finger Lakes Hub Task Force. This is just my interpretation of State of the Union. I'm going to be very, very surprised at this point unless something changes dramatically, if any individual practices get vaccine probably before springtime at this moment. The reason why is several-fold. Number one, they are seeing value and preferentially sending vaccine to places that can do high throughput. Number two, there is a lot more fear of what happens when a 10-dose vial of Moderna gets popped in a clinic and they can only administer 7 doses. So the potential for wasting doses goes up the more incrementally it gets distributed. The other thing is the distribution is still just complicated. And so distributing it to smaller number of sites that can be kind of coordinated very easily is a heck of a lot easier than to distribute it to hundreds of sites, as you can imagine. So anyway, take that for what it's worth. I have no grand insight that it will not be coming to practices. And just by the fact that I just said that means all of you will likely receive a tray of vaccine this afternoon. So you're welcome if that's the case. But my estimate at this point is that none of us are going to be getting vaccine anytime soon. It'll be going to these large distribution hubs for the short term. Next little bit. So as soon as I say that, the Biden administration announced yesterday, for those that didn't hear, that they have negotiated with both Pfizer and Moderna to buy 100 million additional doses from each. So several things I will say about that. Yay, number one. That equals the total number of doses that we have gotten from both distributors to this moment. So that will be effectively doubling the amount that we expect to have from them going forward. Number two, as great as that is, the anticipated delivery is by summer. So while that will help with the anticipation that by the end of summer, if the Biden administration has their way, there will be 300 million doses administered, it is not going to help with the amount of vaccine that hits the zone next week or the week after or by April. It's not going to be delivered that fast. The vaccine's being accounted for across the entire world by what's readily available. Number two, and what I haven't heard yet, and insert concerns about a capitalist society here, both Pfizer and Moderna had asked the federal government, or had suggested to the federal government, that they would like the 100 million doses they promised to include the 6th dose of the Pfizer vaccine that's coming out of each vial and the 11th dose of the Moderna vaccine that's coming out of each vial. And or they want to be paid for those extra doses. So the government bought vials. They didn't buy number of doses, but they were promised 100 million doses. So Pfizer saying, we promised you 100 million, we gave you X number of vials, you're actually getting an extra dose out of each one. So that counts towards my 100 million, because they want to then be able to sell those other vials across the rest of the world. I don't know, but I suspect somewhere in the, because I didn't hear the resolution, but I suspect somewhere in this we'll buy 100 million more. Some resolution of that has come to be, but this is an incremental 100 million doses of each. Whether we paid an extra dollar amount for it, believe it or not, the Biden administration doesn't clear this through me, so I really have no idea. I'm just happy that we got them. That's all that matters to me. I wish we could have bought 300 million more, for all I care. But that's where we stand at the moment. So there will be more Moderna and Pfizer that will get us closer. Right now, the anticipation is that if we get 300 million people vaccinated with the influx of vaccine, the way they're planning it, it would take until the end of summer is the current plan. So that's relatively good news compared to the fact that we were estimating 1.7 years to get everybody vaccinated just a couple weeks ago. So there's that. The final thing, there's been a lot of discussion, and I've actually even asked the U of R marketing department and infection prevention folks have been doing some kind of market-based research and of patients and I think even some providers in the region, looking at what the hesitancies are for people getting vaccinated. We're supposed to get a full presentation of that next week, but to date, there's been a lot of questions. So people, Moderna is the one that's inciting the most concern at this moment. So it is popular press that the second dose of Moderna vaccine, it is worse, that people have more reactions, they have more adverse feelings. So we have patients who are either saying, no, I don't want to sign up for Moderna, I only want to sign up for Pfizer. Or people saying, you know, I got Moderna, can I get a second dose of Pfizer because I heard what happens when you take the second dose of Moderna. So I think, and that's just a couple of examples, my biggest fear is when the Johnson & Johnson vaccine gets EUA, which could be within the next 2 weeks, if it comes out with a 90% efficacy, which is what their trial endpoint was shooting for, we've already heard of patients who said, I don't want Pfizer, I want Moderna because it's 94 or 95. I want the one that's 95. I can only imagine if it comes out with 86, which the FDA said it will not approve an EUA unless you're at least 80% effective. If it comes out with an 86% efficacy, that people are going to say, oh, no, I don't want to get the Johnson & Johnson. I'll wait until I can get Pfizer or Moderna. That will grind this to a halt. So several things. Number one, and you know, this is for you guys, but hopefully we'll be able to provide some educational materials shortly that you can use and share. I think it's going to be critically important that we tell people that, you know, when we talk about flu vaccine, 60, 70% efficacy is amazing. So people, I think, in the world have now taken the tack that vaccines are 100% effective. And so this one's just not quite as good, but it's better than nothing. You know, 80% would still be astronomical for most vaccines. Number two, if you bypass your opportunity, and we're seeing this already, 70-year-old patients who are getting a call and offered Moderna and they're turning it down because they want to wait for Pfizer, you don't stay at the front of the line waiting for the next Pfizer clinic to open. You go to the back of the line and you get re-randomized. So I think people need to appreciate that when you get the call, you know, Willy Wonka only opens the chocolate factory so many times, you take it and run because you get it now. That's the way it is. So I think the overall reactions are rare. Number two, the people who have reactions from the second dose of Moderna, it means your immune system is working. That's a good thing. So high five yourself. That's a good day. So, you know, I didn't feel crap after my second dose. It makes me kind of worried that maybe I didn't get much out of it. I'm kind of worried about that. So I think, you know, we need to make sure that we convey this as much as humanly possible, because I worry that this is going to have a ripple effect of people getting vaccinated, and especially people in populations that are prone to have suspicion about vaccines or about this vaccine in particular. I worry that anything else that gives them leverage is just going to delay that herd immunity or ability to widespread vaccinate that much more. So hopefully we'll have some of those materials that we can begin to share with you guys, so it doesn't look like we just made this up on the fly. But there, we'll have that because it definitely seems to be more pervasive. Next thing, on Monday, I think it was actually over the weekend, we got several folks who were asking about recommendations for double masking. Specifically, the question that came was, we're seeing a patient who we think has COVID-like symptoms. We're wearing an N95, we're wearing a face shield. Should we also wear another mask? Should we double mask with our N95? I answered that question and then immediately realized that either the world hates me or that I said things that I shouldn't have said. I made my answer too simplistic. So I will stand by the fact that there is no evidence that you need to double mask with an N95. The data would say that that is good and sufficient in and of itself. Because the world hates me, Tony Fauci, I think, got our email on Monday and then decided to come out Monday night and say, intuitively, double masking is the right thing to do. Thanks, Dr. Fauci. The more complete answer to that question is and should have been that it is true that double masking, if you're going to wear a surgical mask or cloth mask, if you double mask any component thereof, that especially if those two masks are made of different textile, different fabric, different formulation, that you likely are providing an increased barrier, and especially because cloth masks are more form-fitting than the typical surgical masks that always leave the little bubbles at the side. It probably is advantageous to double mask if you're going to wear a cloth mask or a surgical mask. If you're in a healthcare setting and have access to an N95, or if you're in the world and you have access to an N95, because those are becoming more readily available, there is no great evidence that you need something in addition to an N95. So the best I've seen to date is that double masking probably gets you about 75 to 80% blockade protection. N95 is obviously 95%. Triple masking, which now I think you're just trying to show off, gets you to probably about 90%. But N95 plus cotton mask of some kind, people definitely do it. I just don't know that it's adding a lot. So that is the full answer. That is the Tony Fauci approved answer. And that has followed the best data that exists today. But currently the scientific evidence says if you've got an N95 and a face shield and you're interacting with a patient, the cloth mask probably isn't bringing much else to the party. So there you go. I was not arguing with Tony Fauci, but nonetheless, I realize I said something horrible, and so I take it all back. And we'll clarify that again today. LJ, you want to do your update about the
Sure.
symptomatic lab testing?
Sure. I think for those of you who were on the call on Monday, you heard a question come up from one of our practices about concerns as to whether the labs would actually still see and draw blood from a patient who screens positive for fever or who has COVID. So we did clarify that, the screening protocols at the labs are put in place to assure that, not to turn patients away, but to assure that their lab techs and providers are appropriately masked, have everything that they need in place to be protective. So you do not need to worry. With the case that was mentioned, with a little follow-up from that practice, it was a different issue at hand. But to answer the question, you can send patients who are febrile, you can send patients who have COVID who need to have lab testing done. There's no intent on the part of the labs to redirect patients to an emergency department or urgent care center or other site for that. The one thing I would say, which would just be good practice, is if you do have a patient in that who falls in that category, you're sending them for labs, you're concerned about them, I think it's a great opportunity to just place a call to the lab and let them know you're sending that patient and what the situation is. Just again, just good communication, warm handoff is always a good thing if you can have a staff member or someone do that. And then the only other thing I wanted to say, Chad, there's one question in the chat about that the folks who are doing the immunizing at Strong are now saying don't take ibuprofen after the second dose. So I wonder if you wanted to talk about that or.
Yeah, so this has come up, and this is both for ibuprofen and Tylenol. that there is some suggestion that the effect of a vaccination in folks who pre-medicate with Tylenol or ibuprofen may be tempered, that you actually want to have the full reaction. So, what I've now told, there was one study that actually suggested the efficacy of the vaccine could be reduced by somewhere in the 5 to 8% kind of range. I don't know if that's a standard thing. That's just the only thing I could say that I could find that gave me an actual uh, percentage of what the reduced efficacy may be. So, I think if folks are just on death's door and need something, I guess I would take it after the fact. I would probably not recommend people pre-medicate. And, I think for most, just enjoy that that's showing that it's working, and that that's a good thing. So hopefully that'll help people. Oh, you're muted, LJ.
I just like to talk to myself. Thank you. One other clarifying thing, when you spoke about the change in testing for pre-procedural patients and allowing the saliva or the nasal swab PCR test, I just want to make sure that people are very clear. This does not change the sampling method recommendations for symptomatic testing. That is not changed. And it's still the same thing. If for some reason a symptomatic patient gets an antigen test and that test is negative, they still need a backup PCR test to assure that piece. So I just want to make sure that it gets so confusing with all these different testing modalities and guidance that we think very clearly about asymptomatic versus symptomatic. That's it.
All right. The only other thing that I wanted to say, and I think we shared most of this before, the allergy, immunology, rheumatology team at Strong has put out some recommendations regarding prohibitions for receiving the vaccine. And there's been a lot of, I'll say, maybe conflicting information about who should or shouldn't receive the vaccine. So the only absolute contraindication is in 3 groups. Number one, those who have had prior reaction to a COVID vaccine. Don't know how you would know that necessarily, but if you've had, then obviously that precludes you, or at least you should see an allergist beforehand. And they are taking the incremental leftovers from vials to actually do sensitivity testing in that population. Number 2 and 3 would be if you've ever had reaction to a vaccine or any ingestion of polysorbate or polyethylene glycol. So those are 2 of the kind of carrying agents that are in the vaccine. Probably would only know that from prior ingestion. Definitely not something I would say that most of the world would know that they have allergies to. But those are really the only 3 groups that are absolute hard stops without seeing allergy first. If folks have had reactions to any other vaccine, at least for Moderna and Pfizer, they can pre-medicate with Benadryl or Claritin or whatever before coming in, but there is no other absolute contraindication for them getting vaccinated. And there is no reason that if they don't have one of those 3 categories, that they should see allergy or immunology first. Because I know a lot of people are getting delayed or not going to get the vaccine because it takes a very long time, obviously, to get into AIR. So they're trying to expedite that by, making that cutoff. And then number 2, really focusing their attention on the people who really need it. Obviously, this story will change when and if these other vaccine manufacturers come to market. I do see this question. WHO says pregnant women should not get Moderna vaccine. So this actually, Erica Dobson brought this up today, the pharmacy team, and we can share this. So this actually got a little bit confounded. So what they're not saying that they shouldn't. In fact, let me read what Erica said, because she said it much more eloquently than I could. Oh, there you go. Wow, look at that.
Wow.
Man, you guys are quick to the punch. I don't have to read anything at all. You guys are doing this all by yourself. So there's insufficient data as to which one that they should get. You guys can read this as well as I can. I'm a bad reader in public. So there's no preference. There's no absolute contraindication. The ACOG, the chief of OBGYN at Strong, everybody is saying get vaccinated. by whichever vaccine you can get, because the adverse consequences of COVID infection and pregnancy are pretty significant. So this is another one that unfortunately popular press has amended this, or I'm not saying intentionally, but they've not fully outlined exactly what the WHO put forward, and I think it's confusing and concerning a lot of folks. So there's the answer to that one. I think that's all I've got.
Chad, there's one more question in the chat from, I think it's Stony Brook Peds, wondering if a middle ground has been found between schools and providers for a return to play protocol for a child who's had COVID. I did mention a little bit, and pointing out that many school attorneys are recommending schools not follow this protocol at all. And so I did mention this a little bit on Monday. Honestly, at this point, I mean, just so that people know what we're doing, this has gone beyond needing to have parents do the return to play for kids for PE. There are schools who are saying they will not do anything at all for their athletes. And you've got two different extremes. You've got some schools that are asking PCPs to do a second assessment on these kids, have them come back again and re-release them once they've done this return to play, which does not make any sense. And then you have other schools who are not paying any attention and just letting their athletes just come right back in right after they've been released. So to me, we're throwing out the baby with the bathwater, right? Like this, what we really want, I think, is some focused attention on the adolescents who are in sports and, you know, who are really pushing the limits on some of their physical activity right after COVID. So what we're doing collectively as a group, this sort of consortium team that's been developed here in Rochester and now is partnering with Buffalo, is we're raising a ruckus at the AHP and really asking them to relook at this guidance and pointing out what is happening in our community because of this broad category and sort of relatively non-focused approach. And hopefully if we can get them to narrow the guidance a little bit, we can go right to state ed and to DOH and the governor and ask for there to be some mandate, but we cannot get any kind of mandate around the guidance that is there right now. So honestly, it's this is something that's driving me completely crazy. If anybody wants to know, just talk to my family about it. But we will do our best to get some resolution on this as quickly as possible, especially as we pointed out to the AAP, considering that now our high-risk sports are coming back as of February 1st. And so what a time to not really be focusing on our athletes. This just doesn't make any sense to me at all. So if anyone else, I will say this, if any of you pediatricians on this call have influence, I'm happy to share with you the letter that we have sent to the AAP. Pat Brophy is elevating this. You know, we need to be able to do the right thing for these kids, and they could help us in that. That's it.
Perfect. And Erica just highlighted the follow-up in the chat about the Moderna vaccine. Unfortunately, you know, it seems like almost every day there's a new report or statement that just doesn't fully give the correct answer and just adds to that hesitancy amongst a new group of folks. So it's going to be a constant combating that discussion probably for the next couple of months, unfortunately. The other discussion I will just mention to everybody as a wrap up is, you know, folks can throw things in the chat room or chime in if they have questions. There's been a lot of discussion around randomizing of folks with chronic disease. And you know, admittedly, and rightfully so, there's been a lot of concern that this 67-year-old who's running marathons gets randomized to get the vaccine, but this 65-year-old who has widely metastatic cancer and has been in the hospital 2 or 3 times, or 62-year-old that has that widely metastatic cancer can't get randomized to get the vaccine. And isn't that improper? I agree. And I think that it's a very valid discussion point. I think the reality is that it's complicated enough to randomize just based on age. Trying to randomize based on, okay, you know, did you have cancer in your problem list and therefore, you know, you had it 10 years ago, but you're cured? Or are you actively being treated for terminal cancer today? Or are you on hospice with cancer and do all those people get randomized the same way. It gets very complicated very quickly. There has been some discussion from a task force standpoint of if we're going to start with chronic disease, do we start vaccinating anybody who's in the hospital or who is being seen in one of the infusion clinics? Because at least those are folks who have active acute issues. And so that way we'd be catching theoretically the highest risk of the chronic disease, regardless of age. We're not there yet. Truthfully, there's just not enough vaccine to make that a really valid discussion at the moment. But for the moment, we are still randomizing based on age. That is in keeping with what the state has said. The state has not even revised their full list of what the high risk chronic conditions would be. And I think once they realized the pitfalls of trying to define immunosuppression, they started to decelerate that process even a little bit more, because there's a lot of people who claim to be immunosuppressed for a lot of different reasons. That makes that very complicated. So, I think the concerns people have expressed are being elevated to the highest level. They're being debated and talked about routinely. But I think, the answer is right now, it's just pretty darn hard. So probably the closest we're going to get to that in the near term, until, vaccine is more readily available than it is today, is that if we're going to do it, we may start vaccinating hospitalized individuals at discharge or infusion center patients, theoretically, because they have high risk conditions that may up their risk a little bit. All right. Any other questions that folks have? And as predicted, it's 12:57. So I said despite the small agenda, we'd finish at 12:58. So I was close. Any other questions? All right. So that will adjourn us for the week. We will gather again on Monday of next week. Keep the questions coming if people have issues, and we will. Somebody just asked if they activated the microchips in the Moderna vaccine yet. Yes. I'll be after Moderna right now. All right, guys. Have a lovely.
Thank you, everybody.
Thanks for the fun.
Thanks, OJ.
Talk to you soon.